communication. Just to say that we are the clinical care platform. We have a mission as always, which is to improve patient care. And this particular webinar aligns with that mission. Pelvic organ prolapse, very, something which is very common, not easy to quantify. And I think today we are going to be empowered and to learn more so that we can detect, also, respond and ensure that no woman, I don't know, should I say, is allowed to walk around with a prolapse, which we can do something about. Also to say that today's event is accredited for a maximum of 2 clinical points. For you to be eligible for those points, you have to be a member of the clinical care platform. I will share the link later on. But attendance, colleagues, as always, is free. Empower yourself, but to get administrative support and many other services that we offer, you have to be a member of this platform. Before I hand over to Dr. Magagula to introduce today's topic and our presenter, I wanted to say as well that we are launching a coaching program for the Part 1 exam, or what we call the primaries in obstetrics and gynecology, which is your first examination towards your journey to becoming a specialist in this particular field. So I'll be sharing the link later on, but I think there was an email and through the WhatsApp groups we did share. For now, we are assessing your interest in the program. So if you know someone who really wants to become an obstetrician, or they're looking for a registrar post, or they are a registrar and they really want to write their first exam towards this journey, do share the link with them, and then we will communicate further when we are ready. Yeah, let me not waste a lot of time. I have some network issues, or it's my computer, I don't know, because the iPad seems to be okay. Let me hand over to my colleague, Dr. Billy Magagula, who is our host and coach here at the platform, clinical mentor, particularly for programs in obstetrics and gynecology. He does a lot with us, from master classes to webinars, to coaching programs for the diplomats, and we are heading towards the Part 1, Part 2s, and intermediates, baby steps as we go. And I was in Bombela, Magagula. That's why today I have issues. I drove it the way it was a return trip, but yeah, I couldn't connect with you. But I think virtually now we connect. Welcome, Dr. Billy. Welcome.
No, thanks, Wallace. I actually happen to be in Gauteng, the opposite. It's very close. Yeah, I'm just visiting this side for work, of course. But yeah, I know you love Nelspruit. You must just come back home. You are still welcome. Eh? Prodigal son. Man. Otherwise, Aaron, are you good, brother? Are you well?
Hey, Billy, how's it, my brother?
I'm okay, man. Yeah, it's really lovely to have you here, man. I know we did have a meeting around when was it? A year or more than a year ago? When we had, I think we spoke about incontinence. So it's really, great to have you back.
Yeah, yeah. Previously we spoke about approach to urinary incontinence. Yeah.
Yes.
I'm not well. I think I spent my weekend. I went to the Western Cape this past weekend. So before I left, I think I met some few patients that came from Moria. So I think they gave me some virus from that side.
Eish, man. Yeah, let's hope we won't have you won't have to keep you too long so that you can go recover.
Yeah, I'm hoping so, because I guess we had to reschedule, so I couldn't reschedule again.
No, we appreciate your work, man, and your effort, and your consistency. Yeah. Otherwise, colleagues, many of you, I think, know Dr. Aaron Molefe. He's a friend, he's a colleague, a fellow cyclist. He's a subspecialist urogynecologist, So he has gone further than where we are, some of us at the moment. So he does deal with core urogyne work. He's currently based in Joburg. I know he's lecturing at SMU. He's also running his private practice, in Joburg, that side. So he'll be talking to us about, our approach to female pelvic organ prolapse, which I think it's one of those neglected conditions that can have a negative impact, you know, in the quality of life of women that suffer from this condition. It's very important for us, not only for the elderly women, which of course we care for, but many of our women that have a vaginal delivery. Even one vaginal delivery is enough to give a woman prolapse. We do see that, you know, time and again. So yeah, I think it's really an awesome thing to have Aaron here. And yeah, we are looking forward to your talk. Aaron, let me not take too much of your time so that perhaps you can present, you know, and go and look after your upper airway. Thanks, brother. You may start your talk.
Oh no, thanks. Yeah, maybe just to correct you, I'm not a certified urogynecologist. I'm still a fellow.
Ah, no ways. I know you are. So yeah, it's fine though if you wanna be modest, but it's okay. Thanks, brother.
All right. No, thank you for such a kind presentation, Billy. Thank you for inviting me and giving me this opportunity to come and share the little knowledge that I have with a subject at hand, which is pelvic organ prolapse. So, colleague, you'll excuse me, I've got a bit of a viral infection, but of my upper airway. So maybe I'll pause, take some sips of water so that I can continue talking properly and so that you can hear me loud and clear. So, okay. So our learning objectives. So today we'll just go through some introduction of the topic, pelvic organ prolapse. We'll look at the definition, what it is, and then the support structures that are there, so that we understand why women are not having, all of them are not having pelvic organ prolapse. So we'll look at why they are not having it, right? And then what happens when those structures are injured, and then what happens and all that, right? Then we'll look at the types of prolapse that are there, risk factors, clinical features. Then at the end, we'll just look at how we manage these patients that present with pelvic organ prolapse. So by definition, what is it that, why do we say somebody has pelvic organ prolapse? So it just means that there's herniation or there's a descent of one or more pelvic or genital organs into the vagina, right? So and then we know the organs that are there in the vagina. So we have the bladder, you've got the uterus that is there as well, you've got the rectum, you've got the bowel as well, right? So if any of those organs, they herniate or they protrude or they descend through the vagina, that is called pelvic organ prolapse, right? It can be front, can be back, can be apical, which is the upper portion of it, right? And then what happens is that it's a common condition, as BD has introduced the topic, amongst women, especially with advancing age, right? So, and then we know epidemiologically, like about 30 to 65% of women will have about stage 2 prolapse, right? So those are the patients that come to your gynae practice. They are coming for pap smear, you know, just a routine checkup, and you just pass a speculum. You'll see a bit of prolapse. And then if you quantify it, you'll realize what they have about stage 2 prolapse because they are asymptomatic, those type of patients, right? And about 2 to 7% will have symptoms, right? And then of those that are having symptoms, 11% of them have risk of undergoing surgery for pelvic organ prolapse, right? And this disease or this condition has got a negative impact in how they look. You know, females, they like feeling good and looking good, right? So it affects their physique, the way they feel, the way they function sexually as well, they are affected. And you can imagine that also it's got serious psychological impact as it can affect their quality of life, right? So as I've mentioned earlier on when I was talking about the outline, so most of us or most women, they don't have prolapse, right? The reason is because there are these supporting structures, which is the connective tissue, the ligaments, the muscles, right? And then they are called the lastly levels of support, right? So there's level 1, 2, and 3, right? So level 1 is the upper part, which is the uterosacral or the cardiac ligaments. So these ligaments are important because they suspend there, or they put the vagina and the uterus in position, especially the upper vagina. Né? So that's why it can stay in its right position, right? And you've got the level 2 support, right? Which namely the pubocervical fascia, which is the anterior part of it, and that's the bladder. And then the rectovaginal fascia, which is posteriorly, which supports the rectum, right? So any defect that will occur on this level 2 at the level of the Lancet level 2 support, so you can either have a bladder prolapse or you'll have a rectal prolapse, right? And then we've got the levator animuscle, right? Which is the one that the structures are sitting on, so that they don't fall. It's like a hammock-like structure. They are sitting there. You've got those muscles that are giving that shape that the vulva has as well. So which are the puborectalis, pubococcygeus, iliococcygeus, and the coccygeus muscle, right? So all these muscles, they play a very, very important role in terms of supporting these pelvic organs that we've already mentioned, right? Then we've got the level 3 support, which is the lower part, right? We've got the perineal membrane and the urogenital diaphragm, right? So this also is very, very important. So the reason why the introitus has a certain shape and size, so it's also there to support the organs, right? So anything that will, I'll make an example. For instance, when the mother comes and they give birth, and then the genital hiatus sort of increases or becomes wider, so that poses a risk because now you've got the urogenital diaphragm now is damaged. Probably they even sustain the 3rd or 4th degree tear. Their perineal body is also damaged. You understand? So all this, they will have an impact on the support structures of the pelvic organs. So any defect on these levels, all these 3 levels, it will result in pelvic organ prolapse, right? Let's continue. Drink some water. So some anatomical consideration that we should be mindful of is that the normal support of the pelvic organ is based on mechanical principle, right? So the uterus, the vagina are attached to the walls by the endopelvic fascia that supports the organs from the pelvic side walls, right? Then the levator animuscle that I've just described now constricts the lumen of these organs until they are closed, forming an occlusive layer on which these pelvic organs may rest, right? Then the other structures that are important as well is the paracolpium and the parametrium, right? So basically these ones are sort of not in the pelvic side walls. They maintain the support of the apex, and the defect or injury to all these structures, it will result in prolapse, right? You can see maybe by the imaging that is at the lower level there, where it's normal, the normal introitus, and then on the right side there, there's a uterus coming out. So basically what you have in there, you are having the parametria or the paracolpium or the support structures that have defects. So now there's no proper support, right? So then all these organs will now protrude. Yeah? They will herniate because now the support is completely lost, right? And then what are the types of prolapses that we know, right? So we know initially there's been terminology has changed. Previously, we know the bladder prolapse used to be cystocele, but nowadays we call it anterior compartment prolapse, right? Then we've got cystourethroceal, or we've got the bladder or the urethra prolapse, right? Then we've got the uterus that is prolapsing, that is straight away, it's just uterine prolapse, right? And then if you have a patient that has had a hysterectomy before, and then their vagina or their vault is falling out, so that is called a vault prolapse or the apical prolapse when they have lost the apical support. So here, when you have a vault prolapse, your level 1 support is completely gone, right? And we've got the rectocele, which is the posterior compartment, right? And when you have a posterior compartment prolapse, there you have
Aaron,
lost.
just a second. Sorry, brother. The colleagues are asking if you may use a cursor, if you can, you know, maybe if you're pointing or discussing a particular point there in those diagrams, if you won't mind, if it's possible. Thanks.
Where's the cursor? Okay, is this? Oh yeah, is it visible? My
Yes, we can see it.
Oh,
Thanks,
yeah.
man.
Oh yeah, perfect. Sorry. Oh yeah, so as I was mentioning, for initially, the old nomenclature, and we used to call the bladder prolapse cystocele, right? So if you can look at this second imaging here, or on the top part, so that's the bladder coming down, that's the cystocele, but now we'll call it anterior compartment prolapse. We'll understand it later when we do the staging and all that, right? Then the cystourethral, or the bladder or the urethra when it prolapses, right? Then you've got the uterus. So the uterus can look there in the middle, the lower part. So the uterus, the womb is prolapsing, right? That's the uterine prolapse. Then after once the woman has had a hysterectomy before, usually they don't have the uterus anymore. The only thing that they are left with is the vagina, right? And if they have lost the apical support or the level 1 support, then they'll have a vault prolapse, right? Then enterocele is when, or rectocele is the posterior part, right? Where is the rectum prolapsing. You can see that image on the upper right, right? And the enterocele basically is the small intestine herniating, right? So this will happen especially if in those cases where you are doing a hysterectomy and you don't do like McCall, caldoplasty, you don't support the structure, the wall, because you have removed there was something that was occupying the patch of that class. Now you have removed the uterus. Now the cul-de-sac is completely open, and then you didn't do a proper support at the bottom after doing a hysterectomy. So the intestine, they're gonna come there, they will cause an enterocele, right? So there's basically a defect at the level of the upper, the apical prolapse that was not suspended properly. Then the intestine will herniate through that as well, right? And we've got what we call the perineal descent, right? Perineal descent is when you've got level 1 support, level 3 support that is infectious as well, right? And who is at risk of having a pelvic organ prolapse? So it's quite common in Caucasians and Hispanic, right? So white people are more prone to having a pelvic organ prolapse compared to us black people, right? Then obviously menopause, as by definition, as you age, right, the elderly. So those are the patients that we see them in our clinic. The majority of them are elderly, and they are in their menopausal stage. And then the effect of estrogen and that is low has those consequences of them having the risk of having pelvic organ prolapse, right? Because we know estrogen plays a big role in the synthesis of collagen and all that, right? So if it's not there, then the ligaments, they become a bit weak. Then that's how they end up with having, or that they end up being at risk of having pelvic organ prolapse, right? Connective tissue disorders as well are quite an important risk factor, right? Pregnancy is the most important one, right? So pregnancy on its own, carrying that pregnancy from to term, it poses a risk on the pelvic floor, right? And then furthermore, even if you do a cesarean section doesn't have any protective effect on not having a pelvic prolapse. For the fact that you are pregnant, that weight that is exerted on the pelvic floor, it increases the risk, right? Then furthermore, when you're going to give birth vaginally, the force that the head exerts on the pelvic floor during birth, that will injure the levator, and it will cause levator avulsion, can cause trauma, can have perineal tears. So there's serious trauma that occur during vaginal birth, right? Sometimes we use vacuum deliveries, or we use forceps to help deliver these mothers. So that using those instruments, they actually increase the risk of these patients or these women later on in life having pelvic organ prolapse, right? Anal sphincter injuries, always. So it's also a very important risk factor that we can't forget, right? So the other important factors that we need to look into as well is the family history of prolapse. Smoking is a very important risk factor because smoking will actually put you at risk of having COPD, chronic cough, right? So now what happens is that we've got persistently this increased intra-abdominal pressure, which is exerted on the pelvic floor. So putting you at risk of having a pelvic organ prolapse, right? Increased BMI. We know in our society as well nowadays, obesity is quite a challenge. It's a disease that is increasing in incidence, or the prevalence of obesity is quite sad, because most of people now have either they're overweight or they're now in the class 1 or 2, 3 obesity, right? So increased BMI is a has serious impact on the pelvic floor, right? So that will increase your risk of pelvic organ prolapse in the future, right? Constipation because of chronic strain, that will actually also have an impact on the pelvic floor, right? Repetitive heavy lifting, yeah, you know, these ladies that we see now lifting, going to the gym, lifting heavy stuff, or maybe labor, their work where they are working, it's sort of labor intensive. They have to lift heavy objects, so that has an impact as well on the pelvic floor, right? So, and then these patients, once you've identified them, and then maybe they come now, they have issues, so they'll come to you with complaints, right? So symptoms, I usually divide them in, we've got vaginal symptoms, we've got urinary symptoms, we've got bowel symptoms, and we have sexual symptoms, right? And we get other symptoms, right? So vaginal symptoms, those patients, they'll come and they'll tell you how they feel something coming out of their vagina, right? So these are just examples of patients that obviously these pictures were they are reproduced with their permission, right? So they will present with bulge symptoms. So this patient had procedentia, or what looks like vault prolapse as well. So they will present with bulge symptoms, which is one of the commonest symptoms that they'll present with, right? And then together, because the bladder is anteriorly there, they might have signs suggestive of stress urinary incontinence, or they might even have what we call occult urinary incontinence. So what you need to do when you have a patient and you are not sure whether they've got stress or not. So because of this prolapse, so the organs are protruding, so the urethra has kinked, right? And if this thing you don't assess it when they come to the clinic, you might do a very good job, suspend the uterus or suspend the vault. Then later on, the patient is not happy because now they are coming back, they are leaking. Or doctor, you said you're going to fix my problems. I appreciate that you have reduced my prolapse, but now I'm leaking. Now I have to use pads. Why is this happening? It's because during assessment, you didn't actually assess them properly and reduce this prolapse and ask them to actually demonstrate whether there's element of stress, urinary incontinence or not, right? And they can also present with symptoms or signs suggestive of overactive bladder, right? Which is urge incontinence or frequency. They usually have frequency, nocturia, urgency, right? So what happens is that mainly you will see it in patients that present with a rectocele. So now the rectocele, what the rectocele does, it sort of pressurizes the bladder on top. Now that's a sort of an irritation. So every time the urine fills up into the bladder, there's an irritation that comes in or exerted from the rectocele. So what happens now? They become they have agency to go in and urinate, right? And they will have frequency as well, right? Or what happens is that they now have voiding dysfunction. So now for them to void, or to pee, they have to maybe manually reduce the prolapse so that they're able to void. Otherwise, they are unable to void, right? So those are the symptoms that the urinary system can have, right? Or now they can have bowel symptoms. So bowel symptoms mainly is defecatory dysfunction, right? So they're unable to pass stools, or they have to digitate for them to pass stools, right? Then sexual symptoms. So mainly there's vaginal laxity, there's decreased sensation, there's low libido. Some patients they present with dyspareunia, and because of all these symptoms, they will end up in a psychiatric ward because now they are depressed, right? So if you look at this picture here, that's a patient with who had a cystocele, and this one is just a patient who had an old 4th-degree perineal tear. Of all these things, they can actually result in patient having pelvic organ prolapse in the future, right? And then on clinical examination, these patients, when they come, so when you're assessing them, you're in the clinic there, you need to inspect them as they are coming into your room. How are they walking? Are they walking like they are opening their legs? So if there's somebody walks like that, so you should suspect or probably there's something that is bothering them. Maybe something is protruding. They are trying to walk away from it. Otherwise, or maybe they already have decubitus ulcer because of they've been sitting on this uterus all along, right? So those are you have to inspect as they walk into the room, right? And in terms of abdominal exam, you have to do abdominal exam, bimanual exam, look at the scars, if there are any scars, masses, fibroids, if there's an ascites, so those are the things that you need to look into, right? Look at the perineum, if there's atrophy, especially in postmenopausal patients. I think I did mention earlier on that when you're assessing these patients, you need to ask them to Valsalva, right? You reduce the prolapse, ask them to Valsalva, then you'll see if they've got occult stress urinary incontinence or not, right? Inspect this prolapse with the use of a SIM speculum so that you are able to assess both the anterior and the posterior compartment. So the SIMS is designed in such a way that you're able to obstruct the anterior part, then you're able to inspect properly, and the posterior as well, you can do the same, right? And during that examination, assess the pelvic floor muscle strength. There's an Oxford grading system that assesses the strength from 1 to 5, right? So you need to assess that so that we can know, is this patient having a strong pelvic floor muscle or not? Because if the muscles are weak, then you are able to implement a treatment plan at a later stage, right? Or if you're strong, then okay, at least you are dealing with somebody at this level of strength, then what you need, what exercises they need, and so forth. So that's how assessing the strength will help you, right? And cannot forget to do a PR, right? That's very, very important, right? Just do a quick neurological exam as well, just to assess the sacral pathway, right? Once you have done this, and then you have identified what there's a prolapse, you need to grade it, right? So the grading system that we use is the POPQ system, right? POPQ system is called pelvic organ prolapse quantification system, right? It's a universal system. You can communicate with somebody in the US, in the UK, right? That know what I've got a patient with stage 1. So where it has different points that we can reference to in the vagina. I didn't put much emphasis on it because it's a topic on its own. However, if you know they don't have any prolapse stage 0, then the stage 1, the reference point basically here is the hymen, right? So the hymen is a structure that usually, even if it's broken, you will still see, oh, here's the hymen, right? So that's your reference point. So anything inside is stage 0 to 2, right? Stage 1 is halfway to the hymen. Stage 2 reaches the hymen, right? Stage 3, it goes beyond the hymen, right? Stage 4 is complete eversion, right? So when you have stage 4, it's complete eversion. The uterus is completely out, or the vault is completely out, or the maximum descent of whatever structure. It can be anteriorly, it can be posteriorly, it can be mid compartment, it can be posterior, and so forth, right? So that's basically how. So when you go through literature, you see other grading system like Baden-Walker halfway system and all that. But however, now the preferred system of grading or staging the pelvic organ prolapse is the POP2 system, right? And what investigation are you going to do, right? The investigation of choice, I mean, we all have ultrasound, right? So this picture, we did it with our Prof Abdul in our unit. So she always has workshops on how to do the 2D, simple 2D transperineal ultrasound scan to assess pelvic organ prolapse. So this is how you place your probe. It requires training. You need to attend one of the workshops so that you can understand how to do this dynamic 2D ultrasound, because it's accessible, it's inexpensive. It's the same as doing your TVS or your abdominal scan for your patent patients. So you can just take probe, put the glove, put on the perineum, and then you should be able to see what's happening. You'll see the symphysis pubis, you'll see the urethra there. This is the bladder, that's the uterus. You know, then you'll see the anal canal and the rectum at the back there, right? So it's very easy when you know what you're looking for. So it just requires training, right? So transperineal ultrasound is something that we can do, easily accessible. With most of the gynaes, they have it in their rooms, right? You can do urinalysis, obviously, if the patient has urinary symptoms. It's important so that we can exclude UTIs, right? If it's a bit of complex, maybe you're not sure what is happening with their urinary symptoms. They are maybe presenting with stress incontinence or mixed urinary incontinence, or you don't know what actually is going on, right? So you can do urodynamic studies, right? And you can also measure the post-void residual volume, especially in those patients that have got a cystocele, right? Those ones that have a cystocele just need to see if they don't have more than 100 mils of urine left, right? So if they've got high residual volume, it means they've got a serious voiding dysfunction, right? So that's how you'll be able to determine or to corroborate this voiding dysfunction that they have, right? So in summary, what we have discussed so far, so in terms of making a proper diagnosis of pelvic organ prolapse, you need a proper detailed history, patient symptoms, the onset, the severity, the risk factors, right? You need to do a physical exam using your sim speculum, preferably. Can use a casco, especially if maybe you want to see the middle compartment, which is the uterus, right? So the sims, I mean, the casco will be of value, especially maybe if you are suspecting maybe this patient might be having maybe cervical elongation, you know. So you can see the cervix is coming out. So you don't know whether it's the uterus or they've got a long cervix. So maybe that's where the casco speculum might be of value as well, right? Ask them to Valsalva, right? So ask them to Valsalva. So when they Valsalva, you'll be able to see maximally. So they must push. You ask them to push, or you ask them to cough, persistent cough, so that we can be able to reveal this prolapse properly, right? And assess it and grade it using your POP-Q quantification system that we briefly spoke about. And then after that, you can do your imaging, your dynamic imaging or with an ultrasound, transperineal ultrasound, right? Do an MRI, complex cases or recurrent cases, right? Maybe you did a repair or something, patient come back, then you're not sure what's going on. Maybe they've got a diverticulum. When you thought it was a cystocele, maybe there's a diverticulum. Then you can do an MRI and so forth, right? So basically that's what we have spoken about for the past couple of minutes, right? For the past 37 minutes that we've been talking about, right? Then now we're going to go to management, right? So when we manage this patient, So when we manage this patient, you need to understand what stage is it. Because stage 1, there's no need to do much. Stage 2, is quite, majority of patients, they have got stage 2, right? And sometimes they're not even symptomatic, right? So the age plays a role as well, right? How old is this person? How old is this patient, right? The symptoms that they are presenting with, does it have any impact on their quality of life, right? The patient's overall health status. So we've got a patient, she's diabetic, hypertensive, cardiac lesion, cardiac failure. You understand? So those are the patients that you'll have to offer them certain treatment options, right? You can't just take that patient to theater, you might finish them off, right? So you need to know what kind of patient are you having here. Are there any future fertility desires, right? So this is also very, 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 very important, right? I've got a patient that we did sacrohysteropexy a couple of weeks back. 37-year-old had a traumatic birth, vaginal birth. They had to use forceps, and this is in private, by the way. So now she came in here. Husband is complaining, or when during intercourse they feel something. So it's the uterus. The uterus, the apical support was completely gone, right? So we had to lift the uterus, fix it to the sacrum, right? So that's what we did. This patient still wants to fall pregnant, right? Still wants to increase her. She only has one child, but she still wants more. So those are the things that we need to assess, right? And then obviously, the main aim of managing them, we want to restore the anatomy and the function, right? And how can you do that? So you can be able to do that, either you do it conservatively or you do it surgically, right? Surgically, you can open. At Steve Biko, we're not that advanced as yet, so we still do open. And then I've worked with Prof. Sliman. She does them. I mean, he does them robotically as well. I've observed some few robotic procedures with him. And then the Kipton guys, they're advanced. They do laparoscopy and they do robotic as well. So there are a couple of options that we have. So depending on your skill, you do what you are comfortable with, right? So conservative, which is non-surgical, the first things are first, right? So you need to sit down and understand lifestyle modification. Let's modify your lifestyle. So what are the issues here? Issues on the table, this patient has got high BMI, work on the weight loss, get a dietitian, put them on a proper diet and so forth, exercise program and so forth, so that they can lose weight, right? If they are constipated, manage their constipation, diet as well, that's what it plays a role. If they lift heavy stuff, they should refrain maybe from doing that. Right? So those are the discussions. You need to discuss with your patient all these things, right? Pelvic floor exercises, or called Kegel exercises, they are very, very important as well, right? You do them through, it's a prescription that physiotherapists, they usually prescribe to the patient, and it's exercises that they can actually do whilst they are sitting at the desk, if they are working, or if they are waiting in the rooms, or somewhere in the house, comfort of their house, they're watching TV, they can do these Kegel exercises, about 10 minutes, 3 times a day. It's good. So they must feel that maybe if they want to pass wind, can show them, okay, you need to squeeze your muscle, and then that's how you actually exercising them, right? So that's how they are strengthening them. You did assess their pelvic floor strength, using the Oxford scoring system. Now you saw it's weak. You know which muscle you need to work on. That's how you'll be able to prescribe it. Then pessary use. Pessaries are very, very important. They offer mechanical support. However, it requires fitting and maintenance, right? So we've got different types of pessaries. So we've got the rim pessary, we've got the donut, we've got the gel horn, we've got the cube. So basically, you've got, with pessaries, it's a topic on its own that we can have another discussion on it. So we've got space occupying pessaries, and we've got non-space occupying pessaries. So space occupying, it means they're going to occupy the space in the vagina, right? So there you've got the cube, the gel horn, right? So those are going to occupy. They might make sexual intercourse a bit of a challenge. They might have to remove it if they want to have sex and all that. That's compared to the non-space occupying ones like your ring pessary, ring with a knob, or ring with support, and so forth, right? Then for those patients that are postmenopausal, topical estrogen is also an important drug that we can use. So it helps to restore the vaginal tissue. You can use Premarin in the form of a cream, or you can use Vagifem tablets, tablet form of vaginal estrogen, right? Maybe just to look at a bit of literature in terms of when you do physiotherapy intervention. So it plays a very, very big role in non-surgical management of pelvic organ prolapse. So if it's done properly, you can have improvement of symptoms of about 60%, right? And then this study that was done by Panman and colleagues demonstrated significant decrease in pelvic floor symptoms of about 43% when compared to all those people that there were patients that they were just watching them. Then there were patients that were on treatment, pelvic floor rehabilitation program, right? So of those patients, 43% of them had good symptoms improvement, right? So it means physio works if it's done properly, right? Then with pessaries, it can be a bit challenging, especially if you have to fit it, and all that. So there's an article that was published now recently in the International Urogyn Journal, the IUGA, right? They were looking at pessary. This committee basically was looking at pessary management. Our Prof. Zila was part of that team that participated, that looked into or that worked on the study, right? So in terms of when these patients come in our or in the consulting room, they looked at different studies across the world. So majority of patients that basically come, we are able to feed them with pessaries if it's indicated for them to get it, right? Then successful pessary placement in those individuals especially with vaginal bulge resolved in about 90% of those patients. So it means pessary is something that is very good and that it works, right? And then older age women or older age and women who can self-manage the pessary care or the family support were factors that were associated with pessary continuation. So it means if you are going to prescribe a pessary for a patient, you can't just give them a pessary and say, this will help you with your symptoms that you have. So you need to educate them. You need to tell them about how it's done, how to take care of it. And if they usually when they come, because it's the elderly, they come with their daughters or their son and all that. So you need to explain to them. We have now that I'm talking about this issue, I remember we've got a patient. She's deaf, right? So she's got a son. Now the son is the one who translates. So it's so challenging when we have to explain now. We have to explain to the son. The son has to translate what we are telling the mother how to use the pessary because she's using pessary. We didn't operate her, So that type of conversation they need to be had, with a family member, so that at least there's proper understanding, okay, this is how we use it and all that. Show them, you bring them to the consulting room, you show them how it's inserted, how it's removed. Then you'll have a proper success rate, right? However, we know pessaries, foreign body, they can cause issues. So the discontinuation was encouraged by, maybe the size is not the correct one. It came out expulsion, or some patient they feel pain, then they'll remove it. Some they don't want to use the pessary at all, right? So you have those patients, you offer them the pessary, they say no, then those are the candidates for surgery, right? Or they can have erosions, or some they just want surgery, right? Or they come bleeding, or some they didn't see any improvement in their symptoms, right? And then some they develop rare complications like fistula or pessary impaction, or they've got vaginal cancer, which is very, 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 very rare, right? This is a very good article if you are using pessaries to just understand, right? About all right, and then Just a few slides to go. So if it fails, so you have tried all the non-surgical option, conservative options, they fail, or patient requests surgery. You can do surgery, right? So surgery, you can have vaginal procedures, abdominal procedures, or you can have abdominal procedures using a mesh, right? So vaginal procedures, you can have a vaginal hysterectomy. So most generalists, they know how to do a vaginal hysterectomy. So we can do it with or without a suspension, right? Sacrospinous ligament fixation. We can fix the uterus or we can fix the vault, right? So basically what you, the second one, which is the ligament, there's a sacrospinous ligament. That's where maybe let's say you've got, mainly we want to address the apical, the level 1 support, right? So you have lost your level 1 support. So that's why you want to suspend the uterus high up there at the uterosacral ligament, right? So you use a device called capio and all that. So you counsel your patients on what you're going to do. So basically, sacrospinous fixation, sacrospinous ligament fixation is basically meaning that you are fixing that to the sacrospinous ligament, right? And what we can do, we can also do an obliterative procedure, right, which is colpocliasis. So this usually is reserved for women that doesn't want to be sexually active, or they've got comorbidities. You don't want them to spend more time in theater. Then just do an obliterative procedure, right? And the ones that commonly we do is anterior repair or anterior colporrhaphy, which is fixing the bladder, lifting. The patient will say, they'll tell you, oh no, I once had this surgery, they lifted my my bladder up, right? We've got a posterior repair, they'll tell you, no, they fixed my rectum, right? But then we can do what we call a Manchester procedure as well. I think is that when I was talking about cervical elongation, we are just making the cervix shorter. So that's basically what Manchester procedure is all about, right? And then abdominal approach. As I've mentioned earlier on, we can do them laparoscopically, which is better. It's a better way because we've got, you can visualize the tissues very well, the space, you can see those spaces very well, or robotically as well, we can do it. Us at SPA, we're still opening them and we have got good success rate. This is actually the best, when you do an abdominal procedure, is the best procedure, is the recommended one actually if you've got apical prolapse. So if you've got apical prolapse, you need to fix it from the top, right? So you can either do a sacrocolpopexy. Sacro means the sacrum. Colpo means the vagina. For sure, most of us have seen the vagina. And then pexy, you know, is to hook it, like is to fix it, right? So that's basically what it's a sacrohysteropexy. It's fixing the uterus, right? Or you can do what we call uterosacral ligament suspension, right? So these are the procedures that we can do to help with the apical, what do you call, apical support. And maybe to go back, the anterior and posterior anterior repair, posterior repair, those ones will address your level 2 failure, right? So, because that's where you're going to be approximating the fascia, you know, the pubocervical fascia, the rectovaginal fascia. So you're addressing the level 2 support, right? And then vaginal hysterectomy with suspension, you're addressing the level 1 support, right? Are we together? I hope we're together. And then in terms of surgery, so obvious when you do this abdominal surgery, especially the pexy ones, so we have to use the mesh, right? So there are issues with mesh. I'm just gonna mention a few mesh controversies in urogyne. We've got our society here, which is SAUGA, and there's European Society of Urogynecologists, and there's International Continence Society, there's OX, which is the American one, and the NICE one, the NICE guidelines, right? So all of them, all these bodies, if you look at the literature, they all talk one thing. You must be cautious when you're using a mesh. You must start first with native tissue repair, which is the one that is encouraged. Do your patient counseling, and you must know if you're going to put a mesh, is this mesh indicated? You understand? Because we know vaginal mesh for any vaginal procedure, it's associated with serious side effects, right? It's not recommended that you have the routine use, right? And if you're going to use a mesh, you need to properly counsel your patient, right? Detailed discussion on risk and benefits. In the UK, I remember we went there for a workshop there in London. Anyone who does pelvic floor surgery, and whether you're going to use a mesh or not, you need to report what you have done and the outcome of the surgery. They don't sit in their own corners and do their own things, because the government is watching them. You know, there's issues with mesh. You know, I know we don't have this mesh issue with Johnson & Johnson here in our country as well, where there are patients that are suing because of the complications associated with mesh. So native tissue repair, first-line treatment, right? So mesh, you can only consider it in complex cases, and it must be done by somebody who's very, very experienced, that who have used this mesh before, and they know how to apply it, or how to put it in, or how to place it in, and then patients understand the risk and all that, right? So that there are no issues, right? So basically complications, so to be, this is general complications related to the surgery. You can, if you use the mesh, there's risk of erosion, infection. They might have retention afterwards, or incontinence. I think we've mentioned that. Vaginal bleeding or pain, buttock pain, especially when you are going to do sacrospinous fixation, sacrospinous fixation on that ligament that we spoke about, the sacrospinous ligament, or you can even injure a pudendal nerve there, right? Recurrence of prolapse, right? Oh, what I want to say here is that after you've done a very good surgery, there's a risk that they might come back, right? 30% of those patients that you operate, they might come back, especially when you do this cystocele repairs, right? You need to individualize the treatment, discuss with your patient, so that they can understand, or know what we're going to fix your bladder, but there's 30% that you might come back here with the same problem, right? So it's very important to have those honest discussion with your patients, right? So that you don't give them false hope, right? You can tell them these are the issues, this is the route we're taking, right? Individualize this discussion preoperatively. It's very, very important, right? And we've got special consideration. So you've got younger women. So you must consider younger patients. You should consider uterine preserving surgeries. As I've alluded with one of our patients who still wanted to fall pregnant, and we did a sacrohysteropexy for her, very successful surgery, right? Impact on future pregnancies. So if you have done this, let's say you have done sacrohysteropexy, that mesh, because it's sort of enclosing the cervix there at the bottom, so it's gonna behave like a satellite. So you need to tell them we're gonna deliver by C-section, So they must understand that they can't have vaginal birth again, right? Or they're at risk of having issues. So you've got your elderly as well, your frail patient. Consider conservative management or obliterative procedure for them, if surgery might be a bit of a risk for them, right? Yeah, multidisciplinary approach, input for complex cases. Usually we do have combined meetings, urology, they are there, colorectals are there. Discuss these complex cases so that they can be done as a team, in a form of teamwork, right? Teamwork always is better than one, right? And in conclusion, a pelvic organ prolapse is common but manageable. Management should be individualized based on severity and patient preference. Conservative approaches are often effective for mild cases than severe cases. Surgical options offer durable solution but can carry inherent risks. So that's why it's very important to discuss with your patients, right? Patient education and shared decision making are very, very critical. So that at the end of the day, you don't have patient coming into your door with a lawyer. Now they want to sue you because you gave them false hope, right? And then I think that's very important. I think let's end it here. Thank you, colleagues.
Awesome. Thank you so much, Aaron. That was really, empowering, very short, sweet, yeah, and very, very clear. And I do appreciate that, we've got colleagues of different, types of skill sets, and, yeah, we've got doctors, nurses, allied people, etc. And I think the way you presented it is very clear to all of us. Can I just maybe ask one or two questions, Aaron?
Sure.
Would you recommend that a generalist does any kind of this work that you've just presented in terms of treating pelvic organ prolapse? Of course, we need to make the diagnosis. Can I, as a generalist, go in and say, I've noted you've got, say, maybe an anterior pelvic organ prolapse, and I'm going to do something about that. Would you recommend, would you rather say, refer to a subspecialist?
No, I think as a generalist, I mean, if you are comfortable knowing where you are, the spaces, understanding your anatomy very well, I don't think there's anything that impedes you from doing this, especially the vaginal surgeries. It will be a problem if you want to do your sacrocolpexes and all that, because where did you learn them? Who taught you? However, vaginal surgeries, I think most of us, we do work in the vagina. We do repair vaginas now and then for whatever purposes, whether it's rectal seal or cyst seal. But as long as you understand your anatomy and you have a paperwork, in terms of counseling those patients and all that. So I think you can do it if you can back up. You've got knowledge. You have recorded a number of cases where, okay, I've done 100 cyst seals, so I'm comfortable going to that cervical fascia. I know how to placate it. I know which sutures to use, and so forth, right? So as long as you understand those basics, you should be able to defend yourself if there are issues. But don't do it if you don't know how to do it. Don't do it, because now if you don't do it properly, now the tissues will be fibrotic. Now they have to go to another person. Now they have to fix your mess. So if you don't know, don't attempt it. Rather send it to somebody who understands what they're doing.
Yes. No, awesome, man. And maybe one other question for me. Say you've got this patient with apical prolapse. So would you, what is your take? Would you advise for hysterectomy plus minus whatever other procedure, or just, fix the prolapse without a hysterectomy? So yeah, what would be your comment on that? Yeah.
So with apical prolapse, so the problem is the uterus is coming out. The problem is not the uterus.
Yes.
The problem is the support of that uterus is not gone. So if you remove the uterus, you still haven't addressed the problem. Understand? So that's why after, if you do a vaginal hysterectomy, let's say on that patient, they'll come back later with a vault prolapse because you didn't address the issue. So the options that we have there, you can do sacro, you can do actually you can use the same, because the cervix it's quite a dense tissue. So you can use the cervix actually, suspend that uterus on the sacrospinous ligament, right? However, the one that has got better success rate will be your abdominal approach, which would either be laparoscopically or robotic or open, right? So there your options would be to do a sacrohysteropexy, or can even do a subtotal hysterectomy. Then usually use the cervix to suspend the vault onto the sacrum. So instead of doing, because if you do total, so there's a risk of, because you're going to use a mesh there, so there's risk of erosion, So if you are planting it on the cervix, so the risk of erosion, mesh issues there are quite less.
Yes. No, awesome. And I think you've just answered one of the questions in the Q&A by Anonymous at 1929, where they're asking, do you still do sacrocervicopexy? So I think, you've already addressed that question. No, thank you so much, man. Yeah, because I know it's always a debate, to say, do a vaginal hysterectomy because that's what is prolapsing. And I'm always of the opposite opinion, to say perhaps that's not the issue. The issue is the support structure that needs to be sorted out. Yeah,
that's right. Absolutely.
Thank you so much for that, brother. I will just maybe Alice, with your assistance, please, brother. The Q&A, just maybe one or two questions. I'll look at 1855.
Yeah.
So question is basically don't fall pregnant if you don't want a pelvic organ prolapse. Would you advise? And then maybe I'll link this question of pregnancy with another one where they ask, what is it that you must now do if a patient is pregnant and they've got a prolapse? I saw a question like that somewhere in the Q&A. So maybe just your comments on pregnancy and prolapse. Would you advise people to not fall pregnant in fear of having a prolapse? You know, if they are pregnant now, what do you do? Do you terminate? Are the pessaries that you can offer the patient?
Yeah, I think with regards to pregnancy, I think you can, yeah, as you've mentioned, you can use pessaries if it's quite symptomatic. So pessaries will be a better option because operating them, you might put them at risk of what do you call preterm labor or miscarriages and so forth, right? So, and then, however, I think the other discussion that, you know, we always have this discussion with pregnant women about Down syndrome, about anatomy scans and all that, preterm labor, doing cervical lengths and all that. I think when you counsel them about delivery, you know, I always counsel my patient, I mean, if you are going to give birth vaginally, know that you're increasing your risk of having a bladder prolapse at later stage, right? So I always tell them, and then they make an informed decision whether to do C-section or to do a vaginal birth, right? Especially if they don't want a lot of kids. I'll say if you don't want a lot of kids, there's no need to traumatize your pelvic floor. You might as well opt for easy way out, right? However, some women you feel like you are taking that privilege of being in labor and pushing the baby out naturally, you know. So sometimes you just need to individualize that discussion with your patient and sort of get what is it that they will prefer, right?
Awesome. Thank you for that. Anything from your side, Ellis? I just need to take
it's no, I think the issue of Caesar versus normal vaginal delivery, considering all the other challenges we might have, but I think we can discuss that now. Let's go through the questions. Anonymous says, can anal sex be a cause of pelvic organ prolapse, like a rectocele?
Yeah, obviously, if you are going to introduce some things in the anal canal, so they might cause a bit of weakness. So they are at risk of having rectal prolapse, you know, not the rectocele per se, but the rectal prolapse. Yeah, so there is a bit of risk that they are putting themselves in if they are going to be doing anal sex.
Awesome. So Zippo says, in mild cases that can be managed consecutively, if a patient requests and demands surgery, especially in a low research setting, do we have the grounds to refuse them surgical management? Looking at the success of pessaries, like the old gogos, can you go straight for surgery? Maybe that's the question.
Yeah, that's why you need to. That's what I'm saying with this patient that present with pelvic prolapse, you know. If it's a mild case, so I don't know if the question says mild cases. So in mild cases, usually conservative approach is the ideal. It will be ideal. Right? I don't think it would be wise to be aggressive on a mild disease because there are risk of complications. And what if you go aggressive and you do surgery and then you injure a nerve and they can't walk afterwards? So that's where the problem is.
Awesome. And then Anonymous was asking, if the pessary is removed accidentally, can the same pessary be reinserted? And then where should the procedure be done? Is it the main theater or is it a minor or major procedure? I think that's what the question is asking. Yeah.
Pessaries are just like their office is the devices that you find in the office. We have them in our clinic, so we feed them, and then we show the patient and whoever is accompanying the patient how to use it, they actually must know how to remove it, clean it, and put it back. You understand?
Okay.
So and then they must do that at least once or twice a week. They must clean the pessary. Otherwise, they will have issues with discharge and all the vaginal discharge. You know, they might have risk of erosion. So it's very important to take care of the pessary. So we teach them how to take care of the pessary basically.
Awesome, awesome. So what can be recommended for a patient who has done a total hysterectomy to prevent future organ prolapse post hysterectomy? Is it, yeah.
So basically at hysterectomy, so it's important that after removing the uterus, the vault should be suspended on the uterosacral ligament so that they can prevent future organ prolapse or pelvic organ prolapse or vault prolapse, to prevent vault prolapse. So during hysterectomy, so you must make sure that you do what you call suspension onto those ligaments. The vault, you must suspend your vault on the uterosacral ligaments. Or you can do other procedures like McCall, caldoplasty, or Markovich, of which they also help in terms of preventing future recurrence or occurrence of pelvic organ prolapse.
Awesome, awesome. Let's see. I think this one we have answered it to a certain extent. Due to added risk of vaginal birth on the prolapse, a patient who requests a Caesar for that, what would you advise? I think you have responded to this, but I wanted to ask you, in the public sector, you know, I mean, you know, in a center where there's obstetricians, maybe the decision to do a cesarean section is probably easy. But in the public sector where we have significant complications, would you still recommend a cesarean section just to avoid POP in the future? Because I think there's risks.
Not necessarily. Yeah. I mean, if now maybe we off topic. Now we're discussing pelvic floor support. You know, so at vaginal birth, so you've got what we call perineal bundle care. So where during birth you make sure that you support that perineum. So you can't let the mother push by themselves, which is what unfortunately is happening in most of our public hospitals. So our mother, those women, they are left unattended because of high volumes. So they end up delivering by themselves. Nobody's supporting their perineum. So if you've got proper perineal bundle care or perineal support, you shouldn't be having an issue with doing vaginal birth. So vaginal birth is not a contraindication, or it's not what do you call? You can't avoid it as long as it's done properly. So it will, as long as you protect the perineum during birth, I think you'll be fine. You shouldn't be having, your risk is there obviously for the fact that you are pregnant and you give birth vaginally. There's a risk of pelvic organ prolapse, but if we support it properly, we reduce the risk.
Awesome, awesome. I think this question, Julio, as well, you might have answered it, but maybe he's asking it the other way. Is it best for a sexually active patient with a uterine prolapse to do an abdominal hysterectomy followed by a colpopexy? I thought you were saying during the actual hysterectomy, there's a procedure you can do to suspend the stump so that it doesn't prolapse.
Yes, unless if they already have a uterine prolapse. So you want to address the issue. I think Billy asked that when we did. So I did address it. Yeah.
Okay. Awesome. William is talking about, I think this is more your kinds of questions. It sounds a little bit look, the role of routine caldoplasty during vaginal to prevent prolapse. And Maskovich, I'm going to call it very quickly, during abdominal hysterectomy. It's like the same question, but maybe asked differently again. Am I correct?
Yeah. So we can do, as long as you are able
I'm out of scope for these ones.
You are experienced in doing this, because the risk of doing these procedures is actually injuring the ureters, kinking the ureters and all that. So you just have to know your demarcation, your anatomy very well before you do this type of procedures, because they are delicate. You can easily get into trouble by trying to do a protective procedure. Once you could have done a benign hysterectomy and go out of theater. But if you understand the anatomy well, we can do all these fancy procedures, prevent further prolapse in the future.
Doc, how do you determine the size of the pessary? I think that's what Koresh is asking. Is it a trial and error or there's a method?
Yeah, mainly we do trial and error. I think that's the best way. We can use your index finger measure and see how long. Then you can just check the pessary and measure with your fingers and see which one will fit. Yeah.
Okay.
So usually it's trial and error, because we do have samples. You can test and check which one fits, and then you give the patient the correct size.
Yeah. Chelina, okay, we're going to take the last 3 questions, colleagues, so that Dr. Molefi can rest and recover from the flu. He can't take time off. We need him. There's a lot of plexis to be done. So Chelina is asking, how does one...
Sorry, yeah.
Sorry, I'm making you laugh.
Yeah, making me laugh. Now the cough is coming.
I'm sorry, Doc. Yeah. So Chelina says, how does one tell... Basically, how do you differentiate one prolapse from the other? Basically, bladder from the uterus versus the vault, especially in stage 2 during speculum examination.
I think it goes to so for one to determine the prolapse. So obviously you ask the patient to Valsalva, maximum Valsalva. So by using the same speculum, you should be able to see maximum Valsalva when you have obliterated the anterior part. Then you'll be able to see there's a rectum coming up, or you've obliterated the posterior part. You can see, or both compartments are involved. Then what you need to determine is which one is more prolapsing than the other, so that you're able to stage it properly. And if maybe it's a uterus that is prolapsing, you can use your cascode, and you'll see the uterus coming down as well.
Awesome. So when you started, there was a trending question, because on your risks or epidemiology, you sort of mentioned that it's common in Caucasian women, and people were asking why. But I wanted to ask you, is it prevalent in Caucasian women, or maybe Black people are not presenting, they sort of accept the status quo? I mean, I know of my family elders whom, when they talk to me, I got a sense that they do have a prolapse, but they had accepted it as is. I don't know if they would want to go through surgical procedures to correct it in their 80s and 90s and stuff. What's your understanding of this epidemiology? Yeah.
Yeah, mainly I think it's basically the anatomical variations that exist between the Caucasians and Blacks. So white people have got more wider pelvis as compared to our Black people have got narrower pelvis. So the wider it becomes, the easier for the organs to prolapse. I think mainly it's just the type of pelvis.
But I've heard women, sometimes I listen, I eardrop, and they say, when I cough, I pass urine. I'm like, there must be a prolapse. But are they presenting, Doc? I mean, I need you to comment. Okay, let's leave the shapes. In your understanding, is the health-seeking behavior around prolapse, are you confident that a Black lady who has it will present, or they sort of, are there social norms that will say, I keep it to myself?
Yeah, I think, with course, that's the problem, the stigma surrounding not being able to talk freely, or hey, I think my vagina has got an issue, or so as Black people, we tend to hide these things away.
And we push it back.
Whereas Caucasians, they'll come and tell you, hey, there's something that is coming out here. I don't know what it is. You need to fix it. Whereas with us, it's not that easy. Even when they come to our consulting room, they are very shy. They don't want to talk. You have to dig deep and understand what is actually happening. So I think that's maybe that's our nature as as Black people. So even they're out there, I think we just need to raise awareness of these conditions, that they exist, and there's treatment. There are doctors that are capable of helping them. So maybe sometimes they don't even know, because sometimes they went to a GP, and a GP doesn't know much as well. They are not aware that urogynecists that can actually deal with these conditions. So I think raising awareness, making them aware that these conditions are treatable, we can actually pick up a lot of patients out there. That's why we don't, especially with the topic of urinary incontinence, that's why we don't have proper studies, because people don't want to say, "Oh, I'm using nappies." So they just keep quiet. They leak on their secret corner. Hey, I'm leaking. They just keep it to themselves. So that's where the problem is.
I'm gonna say one thing and then ask you a question. So I know there's a province in this country where after a pap smear, the speculum, just imagine, the speculum was left there. And the lady went home with it. I think she assumed it's supposed to be there for days, you know. But she was brought by the husband. So I want to talk to the prolapse issue, that maybe the husbands, we should be part of the problem, you know, in terms of saying, hey, wife, there's something there. Let's go to Dr. Mulefi and check it out. And, you know, this is a real patient safety incident. When they checked, they found the speculum there. And she said, I thought, because the health worker didn't say anything, you know, so she thought it's supposed to be there after the pap smear. Even in this instance, I think we, the husbands, must also be part of the solution. But anyway, guys, for another date. Go, Doc, let's take the last question.
I need to go. Yeah, I'm sorry.
Yeah, it's the last question. It's the last of the last. In a post-menopausal with anterior prolapse, do you recommend removing the uterus as well? That will be our question finale. Thanks, Doc.
So what is the question again, sorry?
So the question says, in a post-menopausal lady with anterior prolapse only, would you recommend removing the uterus as well?
No, I think you need to assess. If there's no apical involvement, you can just do an anterior repair and then counsel them. There are 30% chances of you having a recurrence, right? Or you can even treat it conservative. You can put a pessary. Usually pessaries, they work very well, understand? So, but if it's a surgical option, just do an anterior corporaphy, anterior repair, and then, yeah, just consider about the recurrence rate. Then if she's happy with that, then you don't have to remove the uterus. I don't usually I will assess them in the consulting room, and then we'll provisionally book them for plus minus sacrospinous fixation when we go in. So when we go in, then we realize, no, this uterus is high up, the apex is intact. We just do the anterior repair, and then we leave them alone. However, if we identify that the apical prolapse, then we should be able to address it in theater. So we consent them for both. And when they're under anesthesia, you're able to do it properly.
Awesome. Thank you very much, Dr. Mulefi, for such an awesome, empowering session. Colleagues, let us go out there to do more awareness, advocacy. Billy, can I hand over to you to close this session?
Yes, brother. Thanks, Aaron, man. I think, it was really an awesome one. I think we really need more and more of these kind of sessions, you know. We don't know a lot of urogyne, and there's a lot of urogyne out there that we need to practice. So I definitely think we need to have another one. It was an awesome talk, very informative, very simple, straight to the point, and I think you've actually addressed all of our confusions and concerns. So we appreciate your time, your effort, you know, and thank you to the, more than 700 colleagues that have sacrificed their evening to just come and learn some urogyne, from Dr. Mulefi. Yeah, thank you so much, and thanks, Alex, for the platform. Yeah, I think we should call it.
All right. Thank you.
Thank you.
Thank you. Yes, colleagues, just two things. If you're not a member, visit our website, join us on this journey. If you want to become an obstetrician, like Dr. Magagula and Molefi here, we do offer part 1 coaching. I've shared the link. For now, register your interest and we will be in touch. Night, everyone.
Bye.